Perfect. Okay. Well, thank you everyone for patiently waiting while we dealt with some technical difficulties. Technology is both a blessing and a curse sometimes, so we just roll with it. Okay, so thank you for joining our I Rise Above webinar today. I would like to welcome Dr. Jenna Canzoniero. She is an assistant professor in breast and gynecological malignancies group at Johns Hopkins Sidney Kimmel Cancer Center in Baltimore, Maryland. Today, she will discuss newly approved oral drugs and indications for the treatment of breast cancer. She will also highlight some exciting emerging oral drug developments. And finally, she will discuss the role of tumor genetic analysis to guide the use of these treatments. So, without further ado, I turn it over to you, Doctor.
Thank you so much for having me here today and giving me the opportunity to speak to this wonderful group. I'm super excited to talk with you all today. Um, I am going to be talking about advances in oral drugs in the treatment of breast cancer. I do want to preface this by saying that most of the current uses for oral drugs are in the metastatic setting, or stage 4 setting. But there are a couple of places where these drugs are being moved into the earlier stage setting. And so I'll try to highlight those particular areas. And my talk is about 25 or 30 minutes long because I wanted to make sure that there was plenty of time at the end for questions. Um, okay. I do have some associations with certain companies, but none of which are going to be particularly influencing what I'm talking about today. So my goal today is to talk about some of the new NCCN guideline indications for oral treatments for breast cancer, and I'm gonna kind of go by drug type. So we're gonna do hopefully not too much of a whirlwind, but a little bit of a quick tour across a bunch of different kinds of drugs. And I'm also going to talk a little bit about some of the drugs that are in development in these different classes. And then I also want to touch a little bit on how molecular diagnostics such as tissue or plasma next generation sequencing, which is sometimes also called liquid biopsy, can help to inform the treatment selection. So I think we're all, oh, I'm going the wrong direction. I think we're all very much aware that the treatment for breast cancer has been rapidly evolving, particularly over the past 5 to 10 years. Originally, the treatment for breast cancer was sort of, everybody got the same back, 50 years ago. And then when they started to recognize the different receptor subtypes, particularly the estrogen receptor, progesterone receptor, and HER2 receptor, as those were discovered and the different targeted therapies were developed for those, then our treatments became very receptor subtype based. But now we're starting to go beyond the receptors and looking more and more at the particular mutations that the cancers have and how can we target those mutations. And that's kind of leading to a new revolution, if you will, in the types of treatments that we have available for breast cancer. And a lot of this has also been brought on by a new focus on PROS, which is patient-reported outcomes. So a lot of these targeted therapies are oral therapies, which patients are able to take at home. They may have less side effects than the sort of traditional cytotoxic chemotherapy. And so even if the outcomes in terms of overall survival or progression-free survival are the same, if we're able to achieve those outcomes with less side effects for patients being able to still live their lives and do the things that they want to do, then that's still a win. So thinking about all of this as we move into this next phase of breast cancer treatment, where we have all this alphabet soup, if you will, of all of these different kinds of targeted therapies that are becoming part of what we're going to be using in our armamentarium. So to get started first, I wanted to talk about PARP inhibitors. So this stands for these are commonly thought of as olaparib and talazoparib are the two that are the ones that are approved for breast cancer. The use of PARP inhibitors does not depend on the receptor subtype. So it doesn't depend on ER, PR, or HER2 status. This has been approved for a while in a particular case, which is for patients who have germline BRCA1 or BRCA2 mutations, then this is an NCCN category 1 indication for either olaparib, which is based on the Olympiad trial, which is shown here at the top. Here we have the progression-free survival in months, where the red is patients who got olaparib and the blue was standard therapy of physician's choice. You can see that patients on the olaparib with germline BRCA1 or BRCA2 mutations did much better. And then there was a very similar study called Embraca, which was using the drug talazoparib, which is shown down here. So this has been a part of our armamentarium for a while. These studies were published in 2017, 2018, but we've had a recent expansion in our indications for these. So there was a study called the TBCRC, which is the Translational Breast Cancer Research Consortium, and their studies are all numbered. So the TBCRC 048. So this was a two-part study. The first part was looking to see if there were other mutations that could potentially respond to olaparib. So the initial results of this were looking at patients who had a germline mutation in PALB2, which PALB2 stands for partner and localizer of BRCA2. So this is a gene that's very closely related to BRCA2. They were also looking for cancers where the patient did not have a mutation in BRCA1, but the tumor had acquired a mutation, so something called a somatic BRCA1 or 2 mutation. And then also looking in the mutations in ATM and CHEK2, which are other genes that are closely involved in this pathway. And so they saw that they had a good response for olaparib in these other settings, germline PALB2 and somatic BRCA. And so what they did is they then expanded those cohorts to confirm that those responses that they were seeing were really true. And so this was presented at ASCO this past year, looking at the response rates for patients who have germline PALB2 mutations or somatic BRCA1 or 2 mutations. And you can see here from this is what's called a swimmer's plot, where the longer you're going over to the side, the better you're doing, the longer you're staying on therapy. Patients who had germline PALB2 mutations had a very good response rate. The response rate was not as good for tumors that had somatic BRCA1 or BRCA2 mutations, but still a good benefit. And so this combination of evidence led to a new NCCN recommendation. It's not a category 1 recommendation, so it's not as strong because this wasn't a randomized control trial, but still a category 2B recommendation for the use of olaparib for patients who have germline PALB2 or somatic BRCA mutations. And so this just expands our options of treatment that we have for that cohort of patients. So that's PARP inhibitors. The next exciting new news that I wanted to talk about is in HER2 tyrosine kinase inhibitors. So these are pills that help to inhibit the HER2 receptor. So the one that I think most patients with HER2 disease are familiar with is tucatinib. And this was shown in the trial HER2 Climb, which looked at the combination of tucatinib, capecitabine, and trastuzumab. And this study was a positive study, and in particular was exciting because this combination of drugs had a lot of activity for patients who had active brain metastases, which is common in HER2 positive disease. So this is an exciting finding. And so this is an NCCN category 1 recommendation to use this in the second or third line. But there was an expansion here because that was for HER2 positive metastatic breast cancer, but we know that HER2 low or HER2 negative metastatic breast cancers can also have HER2 mutations. So one is how much of the receptor you have on the surface, and the other is whether or not the receptor is mutated. And so the question was, do these receptor mutations, even outside of HER2 positive breast cancer, are those breast cancers potentially treatable with these HER2 tyrosine kinase inhibitors? And the answer is yes. So there were 2 studies that I'm going to talk about, one called MUTE-HER and one called SUMMIT. which led to the NCCN Category 2B recommendation for neratinib. So let's take a look at those. So the first one is the MUTE-HER. This was a phase 2 study of neratinib plus fulvestrant in HER2 mutated but not HER2 positive metastatic breast cancer. So these would be breast cancers that we would classify either as triple negative or as ER/PR positive HER2 negative. And so they found that when they treated, and they had a couple of different cohorts. So they had ER positive breast cancer that had previously been treated with fulvestrant. They had some patients with ER positive breast cancer who had not yet seen fulvestrant. And then they did an exploratory triple negative cohort that was treated with neratinib alone. And what they found here, now this was a very small cohort, the triple negative, so it's hard to draw much conclusions from that. But in the previously fulvestrant treated ER positive cohort and the fulvestrant naive ER positive cohort, when they treated those patients with fulvestrant plus neratinib, which again is a HER2 tyrosine kinase inhibitor, they saw some very nice responses here. So this is progression-free survival here. So you can see a good amount of progression-free survival, and this is change from baseline. So they did have some patients that had really dramatic. In fact, one patient who had almost a complete response with this treatment. So that led to a second trial, which was called Summit, which was here again looking at estrogen receptor, progesterone receptor, so hormone receptor positive, HER2 negative breast cancer that had activating HER2 mutations and had previously had progression on a CDK4/6 inhibitor. And here these patients were randomized to neratinib plus fulvestrant plus trastuzumab, or fulvestrant plus trastuzumab, or fulvestrant alone. And for the patients who got fulvestrant and trastuzumab or fulvestrant alone, they were allowed to cross over to get the neratinib arm for a total of 57 patients here. And what you see here is that the response rate, even to patients who had previously progressed on estrogen hormonal-based therapy, when they add the neratinib to the hormonal-based therapy, they got a very nice response with a response rate of 39% and a median progression-free survival of 8.3 months. And this was across different kinds of HER2 mutation types. So HER2 mutations are not the most common mechanism of resistance to endocrine therapy for estrogen receptor positive HER2 negative breast cancer, but they are a known and characterized mechanism of resistance. So we see this in about 5% of patients who've been on endocrine therapy plus CDK4/6 inhibitors. And so this is very exciting to have this. This is a mechanism of resistance, and then have a drug that we can target that mechanism, sort of restore the sensitivity and help people to be able to stay on hormonal-based therapy for longer. So those two trials, again, combined, led to this NCCN Category 2B recommendation. So moving on now to CDK4/6 inhibitors. And this is where I'm going to step a little bit away from metastatic breast cancer and talk a little bit about early stage breast cancer. So if we look in the early stage, we know that abemaciclib has been approved in combination with aromatase inhibitors in the adjuvant setting. So this is after you've had your surgery and radiation and chemotherapy if you need that, for patients who have high risk early stage estrogen receptor positive HER2 negative breast cancer. And that was found in the monarchE trial, and that's been approved now for a couple of years. So we have a good experience with a lot of patients on this. There was a previous study that was looking at adding palbociclib, which is an older CDK4/6 inhibitor in the adjuvant setting, similar design to monarchE. That was not a positive study. So palbociclib is not approved in that setting. So then the question was there something specific about abemaciclib that made this work in the adjuvant setting, or are there other CDK4/6 inhibitors that might work? And we had a very interesting result come out with the NATALEE trial. So the NATALEE trial was similar to the monarchE trial in that it was looking at patients with high risk early stage estrogen receptor positive HER2 negative breast cancer, and they were randomized to either getting an aromatase inhibitor alone or ribociclib plus an aromatase inhibitor, where the ribociclib here is given for 3 years. And what they saw was a significant, to me, this looks like these are overlapping, but this is a very large study of many thousands of patients. And so they were able to get statistical significance. So at 3 years, there was a statistically significant improvement in invasive disease-free survival with 90.4% of patients in the ribociclib arm compared to 87.1% in the aromatase inhibitor arm. But this improvement did come with significant cost in terms of adverse events. So ribociclib, for anyone who's taken this drug before, knows that it does have a lot of side effects, particularly low white blood cell counts and some liver issues as well. So there were quite a few side effects, more side effects with ribociclib compared to aromatase inhibitors alone. But despite this increase in side effects, the FDA did think that this improvement in invasive disease-free survival was significant. And so this was FDA approved as an adjuvant option in September of 2024. So just last month, this became an option that we could use for patients. So it's nice if patients have trouble tolerating abemaciclib because of the GI side effects, or just to have a different option available for patients. It's nice that this is now available in the adjuvant setting. Most of where we use CDK4/6 inhibitors, though, is in the metastatic setting, and that's where they were initially developed and approved. All three of them, palbociclib, abemaciclib, and ribociclib, are all approved as a first-line therapy in combination with endocrine therapy, so typically aromatase inhibitors, but could be fulvestrant, for patients with hormone receptor positive, HER2 negative metastatic breast cancer. But we're not necessarily thinking that all three of these drugs are the same in terms of their efficacy or that they're interchangeable with each other. So there was differences in the way the clinical trials were designed, and so you have to have some caution in comparing across clinical trials. But we do note that abemaciclib and ribociclib combinations did demonstrate an overall survival benefit, whereas palbociclib has not. And we know from a pharmacologic and biochemical standpoint that there are pretty significant differences between these CDK4/6 inhibitors in terms of they don't just inhibit CDK4/6, they inhibit some of the other cyclins as well, and those differ a little bit between the different kinds, between the different flavors of CDK4/6 inhibitor. And so that accounts partly for their difference in benefit and also their difference in side effects. So I think what remains to be seen now, one of the next things that we want to look at is, CDK4/6 inhibitors in the first line have been great in terms of prolonging the amount of time that patients with metastatic ER-positive, HER2-negative breast cancer can continue on endocrine-based therapy. But the question is, what do we do once patients progress on their first line of CDK4/6-based therapy? And the question was, is there any benefit to continuing the CDK4/6 inhibitor and trying a second endocrine therapy? And there's been a couple of studies that have looked at this. The most recent one, which was presented again at ASCO this past year, was the post-MONARCH study. And so this was patients with hormone receptor HER2 negative breast cancer who had previously been treated with a CDK4/6 inhibitor and an aromatase inhibitor in the first line setting. And then they were randomized to either switch to just fulvestrant alone or to switch to fulvestrant plus abemaciclib. And this plot shows the progression-free survival, where the red is the patients who got the abemaciclib plus fulvestrant, where the blue is fulvestrant alone. And you can see that the 6-month progression-free survival rate was much higher for those who got abema at 50% versus 37% for those with placebo. One thing that's important to note about this particular study is what was the CDK4/6 inhibitor that patients got before. And in this study, a lot of the patients had previously gotten palbociclib. So it seems like it's maybe not just a continuation of the same CDK4/6 inhibitor, but potentially a change. And so when we look at another study that was very similar design to post-MONARCH called MAINTAIN, where here for MAINTAIN, they were looking at ribociclib as the CDK4/6 inhibitor that patients got in the second line. What you see here is that for a lot of these patients, so for maintain, almost all of the patients had previously had palbociclib. Very few had previous ribociclib or abemaciclib. And similarly for post-monarch, very few patients had previous abemaciclib. Most of them had had previous palbo or ribociclib. So the question is this really about continuing the CDK4/6 inhibitor, or do we need to switch the CDK4/6 inhibitor? Because essentially, even though these studies allowed a continuation, what ended up happening was that both of these studies were essentially a switch of the CDK4/6 inhibitor. And so I think most providers now are thinking about continuing CDK4/6 inhibitors in the second line if they can make a switch between either abema or ribo. This is, I think, also particularly interesting as we think about the impact of our increasing use of CDK4/6 inhibitors in the adjuvant setting. So previously, patients in the adjuvant setting only got endocrine therapy, but now that we have the approval from Monarch E and the approval from Natalie for using abemaciclib and ribociclib in the adjuvant setting for patients who do unfortunately recur in the adjuvant setting, cancers will have already been exposed to CDK4/6 inhibitors. And so then what is the right first line treatment for them? And so I think that remains to be seen exactly how we're going to deal with that. And I think probably it's going to be about switching the CDK4/6 inhibitor. There's also been a lot of interest in targeting other CDKs. These are cyclin-dependent kinases. These are the things that trigger the cells to go through the cell cycle and continue to grow. So one of the mechanisms of resistance to CDK4/6 inhibitors is CDK2 activation. And so there are multiple ongoing trials exploring CDK2 inhibitors. So this is sort of a picture of this very complicated pathway where these things in red are all of different kinds of pharmaceutical things that are being developed to inhibit these different places. And so the one that I'm most familiar with is this one down here, Blue 222. This is a clinical trial that we have at Hopkins. This is a CDK2 inhibitor. And the idea here is that by inhibiting CDK2, for patients who have become resistant to CDK4/6 inhibitors, by adding that CDK2 inhibitor, that may help make the cancer sensitive to that treatment again. So lots of exciting work being done in the CDK field. Switching gears a little bit to talk a little bit about SERDs. So these are selective estrogen receptor degraders. There's a lot of work going on in the SERD field. I feel like there's a new SERD or a new SERD study coming out every week, or at least, looking for clinical sites. So the one that is currently FDA approved and available outside of a clinical trial is elacestrant. That study was the Emerald trial, which was presented, I think, 2 years ago now at San Antonio, which showed a benefit for using this oral drug in the second line or later setting for patients who've had previous progression on treatment, but they have to have an ESR1 mutation. There's a number of other of these drugs that are all similar, but again, sort of similar to the CDK4/6 inhibitor trial, probably not exactly the same. They're not all the same kind of inhibitors, but there's camizestrant, which is an AstraZeneca product, giredestrant, which is a Genentech product, and imlunestrant, which is a Lilly product. So these 3 other drugs are all moving their way through a large number of different clinical trials in different settings, with different combinations with CDK4/6 inhibitors or PI3 kinase inhibitors. And so I think we'll see a lot more as these come out. There was one that was earlier in development, amcenestrant, but that unfortunately did not meet its primary endpoint. So that one is no longer being developed. But these 3 are still very, and elacestrant too, with combos, are still very actively being developed. There's also other mechanisms of targeting the estrogen receptor. So we have the most common mechanism is the aromatase inhibitors, where we're preventing the body from making estrogen. But then you also have the selective estrogen receptor modulator. So this is your tamoxifen. You have your SERDs that we were just talking about. But then you have other types of drugs as well. So Protacs work by degrading this mechanism. these are the proteolysis targeting chimeric estrogen receptor antagonists. And then you have CERANs, which stands for complete estrogen receptor antagonists. And then you have SERCAs, which stands for selective estrogen receptor covalent antagonists. These are all just different biochemical ways of inhibiting the estrogen receptor, and there is a lot of interest in developing these as well. I think of these ones, SERDs are definitely the farthest along in terms of the number of different products, but then there's also some very promising PROTAC data that is further along in clinical trials too, and so I think we'll be seeing that soon. And this is just the list of the trials that have been done in all of these different classes of ways to target the estrogen receptor. With that, I'm going to move on to the PI3 kinase inhibitors. So this is also FDA approved in the metastatic setting for patients with ER positive, HER2 negative breast cancer with PIK3CA mutation. We know that the drug alpelisib, which is Piqray, it targets both the wild type and the mutant PIK3CA, which is part of what causes its toxicity. This drug has a lot of side effects, particularly related to high blood sugar. So hyperglycemia is a big problem with this drug, and that has to do with it targeting the normal PIK3CA. But there are a number of new drugs that are targeting this pathway that are in development that are trying to target just the mutated version of PIK3CA, so the version that is in the cancer and not hopefully in the normal tissues, with the hope that this will potentially have a better ratio of benefit to side effects, that their side effects may decrease. So, and particularly this relay therapeutic drug here, RLY-2608, has had a lot of good findings so far from its initial clinical trials, but still in clinical trial and still in development. A similar pathway is AKT. So we have an AKT inhibitor, which was just approved this year for treatment of cancers with AKT pathway altered tumors. So this is capivasertib or TrueCap. And so you can see here that this is the progression-free survival for patients who got capivasertib plus fulvestrant in the second or later lines versus placebo, and you can see again a significant benefit. So this is now approved. So we're getting more and more options now for targeting patients who have these mutations in PIK3CA, AKT, or PTEN. PIK3CA occurs, mutations are found in about 40% of estrogen receptor positive, HER2 negative metastatic breast cancer. So this is a large patient population that can benefit from these different oral drugs. As these new targeted therapies continue to be developed and improved, the treatment for metastatic breast cancer is getting more and more complicated, and it becomes even more important to make sure that we're doing a tumor molecular assessment, meaning that we're understanding the mutations that the cancers have. And there's this nice table in the NCCN guidelines that list all of the different mutations that you should be looking for in the current FDA-approved drugs for those. But what the NCCN guidelines does not have is anything about how to do this assessment. When should you be doing this assessment? How often should you be doing it? Is there a particular type of test you should be doing? They are silent on all of that, which makes it a little bit tricky for both patients and providers to try to understand and make sure that they're doing the right test. So one of the first questions is, should we do a tissue test or should we do a liquid biopsy? So liquid biopsy is a blood draw where they look for pieces of cell-free DNA. Those are little strands of DNA floating in the blood. And some of those strands come from the tumor, and so they may be able to identify tumor-specific mutations with a liquid biopsy. There's some advantages and disadvantages to each of these. So with the tissue biopsy, obviously all of you know that that's invasive. It's a procedure, comes with increased cost for obtaining that sample because you have all the costs associated with the procedure, plus all the risks of the procedure. Most of these procedures are relatively low risk in the span of procedures, but they're obviously not zero risk. And so that's definitely something to be mindful of. In contrast to liquid biopsy is blood draw, so it's much less invasive. It's much lower cost to obtain the sample. When you're doing a biopsy, particularly from a metastatic site, one thing we know about patients with metastatic breast cancer, particularly who have breast cancer in lots of different places, is that the genetic alterations may not be the same in all of the different places where the breast cancer is. So you may have a spot of breast cancer in one area that has certain mutations and a spot of breast cancer in another area that has different mutations. And you're only going to pick up the mutations that are in the area that you biopsy if you do a tissue biopsy. In contrast with the liquid biopsy, because in theory, this is catching pieces of DNA from all of the cancers in the body, you're potentially more able to capture all of the different types, all of the different potential mutations. An advantage of the tissue biopsy, though, is that you have a much higher concentration of the tumor. And so it's a much more reliable way for detecting the mutations that are in that cancer. And it also allows you to take a look at the cell surface receptors, the estrogen receptor, progesterone receptor, HER2, and PD-L1 for triple negative breast cancer, which you're not able to do from a liquid biopsy. The other thing is that liquid biopsies can be contaminated by something called CHIP, which is clonal hematopoiesis of indeterminate potentials. This is mutations in the white blood cell that don't necessarily have any sort of clinical significance, but can also shed into the cell-free DNA and sometimes makes it harder to interpret. So there's pros and cons to each of these. The question is, when is the right one for each setting? And I mentioned this before, that we know that patients have mutations in different sites of metastases. So you want to try to capture all of these. We also know that breast cancer changes over time in response to treatment. So this was a study looking at patients who were treated with different first-line therapies, aromatase inhibitors alone, with CDK4/6 inhibitors, fulvestrant with CDK4/6 inhibitors, or chemotherapy. And you can see that the changes in ESR1 mutations or TP53 mutations is different depending on what treatment they got. And so this is important, that we need to make sure that we are understanding what the mutations are that the tumor has at a given time. And that's an advantage for the liquid biopsies, and that's something you can repeat fairly frequently. This is a study that we did here called the IMAGE-2 study. Some of you maybe were involved with this study. And this was started by Vered back when she was still here, and then I took it over a couple of years ago. And here we were looking at patients with metastatic breast cancer and looking at liquid biopsies and tumor tissue sequencing at the time of starting a new line of therapy, and then at several weeks. We were trying to identify what was the difference between the genetic alterations at baseline and over time, and how we could use the changes in ctDNA to look at a predictor of response. And we presented this at ASCO this past year, where we showed that for patients who had both liquid biopsy and tissue biopsy, mutations were detected in both 55% of the time, but in plasma, it was detected another 35% of the time, and in tissue, only 15% of the time. So it's definitely helpful to add the plasma to the tissue biopsy in order to get more of these mutations that could potentially be targeted. So the question is, when and how often should you be doing genomic evaluation for patients with metastatic breast cancer? And I will say there is no consensus about this. There are no guidelines about this. And so what I'm going to present here is just my opinion based on the work that we did in the IMAGE-2 trial and other work that has presented by other groups. So I think where genomic evaluation has the biggest bang for its buck currently is in hormone receptor positive, HER2 negative metastatic breast cancer. This is right now, today, 2024. This is the type of breast cancer that has the most approved targeted therapies. So here, I recommend that you get next generation sequencing of the tissue at the time of diagnosis, because typically here you're getting a tissue biopsy anyway to confirm that the metastatic, that this is truly metastatic breast cancer. and also to confirm the receptor status. So we need to get the baseline ER, PR, and HER2. And so since you're going to get that tissue biopsy anyway, it's helpful to sequence that at that time. That is not going to necessarily inform your first line of treatment because the first line of treatment would still be CDK4/6 inhibitor plus endocrine therapy regardless. But it does help to identify founder mutations that could be targeted in later lines so you can be sort of prepared for what your next line of therapy would be. And then after patients have had progression on their first line of therapy, I recommend getting a second test, which is a liquid biopsy here at this point. And here we're specifically looking for acquired ESR1 mutations, which we know happen when patients are exposed to first line endocrine therapy. And then I think those two, I think it's clear to say that there's a good indication for those. Whether or not there's additional benefit at later times, I think is a little bit harder to say for sure. But I think that will increase over time as we have more and more targeted therapies developed. In other settings, so for triple negative breast cancer, again, there's less targeted therapies for this, but there are some, particularly if we identify mutations in BRCA1, BRCA2, or PALB2. So for triple negative breast cancer, I recommend doing the sequencing at diagnosis from a tissue biopsy when you're getting your tissue done. And then for HER2 positive breast cancer, this is blank here because this is where I think there's the least clear evidence. So right now, all of our HER2 targeted therapies are based primarily on targeting that HER2 amplification. We don't have any targeted therapies that are based on identifying mutations as mechanisms of resistance. So right now, I don't think there's really a strong indication for doing this sequencing from a clinical standpoint. Certainly a lot of interest in doing it from a research standpoint, but from a clinical standpoint, there's no targeted therapies, so less clear what the benefit of doing this at that time is. So with that, I will stop and I am happy to take any questions.
Thank you for that. That was a really great presentation. I really appreciate that. My camera is off. I can't turn it back on. You have to do that. But
Okay.
I can read. There's a few questions here. The first one that came in earlier is, if one is taking Ibrance with an aromatase inhibitor, should they also take Zometa or reclassed for osteopenia?
Yeah, that's a great question. So it depends on a couple of different things. I'm sorry, I'm trying to figure out how to turn your um video back on, and I am not
It's
like we were
it,
talking about earlier. There's too many.
yeah.
You have too
If
many
you go where
Zooms.
participants is,
Okay.
and then you can see me as a panelist, and you can just click my video back on.
Oh, okay. Oh, it's not. Oh, now I muted you. Whoops. Ah, okay.
I can,
Um,
I might be able to reclaim host here. Let me
yeah,
see.
there we go. Sorry, thank you.
There you go. Okay, got it.
Um, yes, so that question was about aromatase inhibitors and palbociclib and whether or not you should take reclassed for osteopenia with those. Yes, so an excellent question. That depends on a lot of different things. So presumably if you're taking an aromatase inhibitor plus palbociclib, that is not approved in the adjuvant setting. So that is only approved in the metastatic breast cancer setting. So that would be the space where that would be being used. And there, the benefit of reclass has to do a lot with whether or not you have bone metastases. And so bone is a very common place for breast cancer to metastasize to. And so it is often used to help strengthen the bone around those areas of metastases. Zoledronic acid is often used to strengthen the bone around those metastases. And there it's given at slightly different dosing. We actually typically refer to that as Zometa, even though it's the same drug, zoledronic acid, because that's often given either every 4 months, every 4 weeks or every 12 weeks. So once a month or every 3 months to be given a little bit more frequently to try to help stabilize those bones around the areas of metastases. Now, for patients who have metastatic breast cancer but don't have any bone metastases, there would still potentially be some benefit because the aromatase inhibitors over time do cause a decrease in the strength of the bones. And so you may still then want to get some zoledronic acid to help strengthen the bones and potentially ward off a little bit, although the evidence for that is questionable, the development of bone metastases. And there you would be getting still the same drug, zoledronic acid, but you would be getting the reclassed version of that, which is given every 6 months or once a year. So it's just a little bit different in the dosing, but I do think that there's a role for either of those dosings, again, depending on the individual clinical situation.
Can I just add a follow-up question to that?
Mhm.
Um, so I've been living with metastatic breast cancer for 8 years, and I've now been off of the Ibrance for about a year and a half. So I'm curious, and I know that I've had bone density tests. At what point is it like a bone density test that then informs the oncologist whether or not they should go for Zometa or not? Or is that kind of what the indicator is at that point?
Yeah, that's a great question. So there's two different kinds of tests that you may need to have. One would be a nuclear medicine bone scan, which is looking there for metastases in the bones. That could also be accomplished with a PET scan. So, you could do one or the other. And so if there are metastases in the bones, then that would potentially inform wanting to do the more frequent dosing of the zoledronic acid. If there's no metastases in the bones, then you may want to look at the bone density to see if there's an indication from a bone density perspective. And so that would be a bone density scan, or also called a DEXA scan, that you would want to look at for that. Those you don't have to do as frequently because the DEXA scans don't change that fast. Usually you do the DEXAs about at most once a year. More commonly, we do them every 2 years. In contrast, something like a nuclear medicine bone scan that you would potentially be doing to follow up any sort of growth or changing of bone metastases, that you would want to be doing a little bit more frequently.
Okay. Thank you for that. We have another question. Casey says, are there any specific therapies for other germline mutations like CHEK2? I don't know if I'm
Yeah,
saying
check
that
two. Yeah.
right.
No, that's great. That's a great question. The answer to that is not yet. So our hope is that there will be other mutations that can target these, but right now the only thing that we have is the olaparib and talazoparib um, for germline BRCA1 and BRCA2, and then olaparib has that expanded. It's not FDA approved, but it's in the NCCN guidelines for germline PALB2. So right now, those are the only ones that we have. But there is a lot of interest in trying to identify treatments for patients with germline mutations, but then also preventative things to give for patients with germline mutations too. Right now, most of our prevention is based on surgical removal of things. It'd be nice if there was a drug that could potentially help with that, but it's still in research phases for right now.
Are there any other questions from the group? Oh, another follow-up. So it reads, follow-up from Casey. So then why do they test us for over 53 genes if they don't have treatments to target them?
That is another great question. So the 53 gene panel is often part of the germline testing panel. So there's to distinguish, there's sort of germline testing, which is things that you may have inherited and could potentially pass on to your children that don't cause breast cancer, but they increase your risk for developing breast cancer, as opposed to somatic mutations, which are things that the tumor acquires as it's going through this process of going from normal cells to tumor. I think your question is about the germline testing. Why do we have these wide germline panels of potentially, it depends on exactly what panel you get, but it could be anywhere from 10 to 50 genes that are on the germline panel. Why are we looking for all of those? So that's a great question. So um, the uh, the answer has to do with how we could potentially counsel patients about their risks for the development of other cancers, because there are certain syndromes that are associated with certain germline mutations that this mutation increases your risk for developing breast cancer, but it also increases your risk for developing some other type of cancer as well. And so that may inform any sort of future imaging or screening that we would want to do for looking at that kind of cancer. So the example for this here that would be good would be like CDH1 mutations increase your risk for developing breast cancer, but they also increase your risk for stomach cancer. And it's not typical that we do any sort of screening for stomach cancer, but if a patient were to be diagnosed with breast cancer and we did germline testing and found that they had a CDH1 mutation, then we would maybe recognize that this is a person who's also at increased risk for stomach cancer, and we should do stomach cancer screening for them, which we wouldn't normally do. So that's part of it. It's also to help inform the risk to any family members too. So if we know that you have a particular type of mutation and your family members are tested, and if one of them is found to have that mutation, we can better counsel them on exactly what cancers they would be at increased risk for and what screenings they should potentially do and at what age they should start those. So we use all of that information to try to help counsel.
That's
Hopefully
very,
that answered the question. It's a
oh, it
complicated
makes,
question.
it makes total sense to me for sure. Yeah. Are there any other questions within the group? These are good questions. No? Well, I have a general question. And coming off of Breast Cancer Awareness Month, I'm so glad I survived it. It was a long month.
A busy month, I'm sure, for you.
Oh yeah, it was busy. The new statistics that have come out just about breast cancer in young people and early detection. And there was this year they changed the age of screening starting at 40.
40. Mm-hmm.
So there's a lot of people within our community who are in their 20s, 30s, and 40s, a big subset of them that aren't eligible for a mammogram until they're 40,
Right.
be covered by
Right.
insurance. And a lot of women have dense breasts. And so even if they were able to get the screening, the mammogram, it may, it may not be seen, it may be not
Right.
detected.
Yeah.
Do you have some advice for young people in terms of, just monitoring their breasts in general? If they've been, there's lots of people that are worried, concerned because it seems to be, on the rise. What advice
Yeah.
do you give to somebody, especially if they feel like something is wrong?
That is a great question. I think anytime you feel like something is wrong, I strongly encourage you to talk to your provider about it. And if you feel like you're being blown off or they're not ordering imaging, advocate for yourself, push for the imaging. Um, you are absolutely right that it's much harder. So there's all this controversy about breast cancer screening, and if you look at different groups that put out guidelines. The radiologists have their guidelines, the OBGYNs have their guidelines, the US Preventative Task Force Services have their guidelines, and they're coming closer together. USPSTF was the one that was really for a long time hard and fast at that 50, and they finally did come down. Um, but there are some differences between those recommendations. But I think a lot of the complication around screening for breast cancer is exactly what you mentioned, which is that mammogram is still a good screening tool, but it's not a great screening tool when patients have really dense breasts. And younger women have much denser breasts than older women. Over time, your breasts kind of lose some of their density, and so it makes the mammograms more effective when you're getting older. So you kind of have to balance that when you're thinking about screening of young women, that we have to have a screening modality that's going to be effective, and mammograms are going to be less effective in the dense breasts of younger women. But to get back to answering your question, if you think that there's something wrong with your breasts, advocate for yourself with your doctor. ask to get some sort of imaging done. And then in thinking about that, what imaging that would be. So oftentimes for young women, because of this issue with breast density, we recommend ultrasound as the first thing to be looking at, particularly if there's a mass that you can feel, then that's best evaluated with ultrasound. And then the other thing that I would just encourage, oh, go
Okay.
ahead.
And so we should, at that point in having the conversation, and we want to advocate for ourselves, just say, I would feel better if I could have an ultrasound of my breast. Yeah. Okay.
Yes.
Hope
Yes.
everyone's hearing that. Because
That's always a fear.
it's something I encounter all the time. Our community is made up of young people, and so most of my cohorts find their own breast cancer,
Yeah.
and some are early and some not so early. They've been blown off, and so I'd like to be able to empower people to advocate for themselves so that they can avoid um, it being detected when it's more advanced.
Yeah, absolutely. There's very low risk associated with a breast ultrasound. There's not radiation associated with it. And so I think, I don't know. My personal threshold is very low for getting a breast ultrasound. If there's something there that we can feel, I'm always happy to ultrasound it. And if it comes back and it's a cyst or a fibroadenoma or all of these other benign things that most of the time that is what it is, then that's great, wonderful news. But if it isn't, I would rather catch it sooner. So, I always encourage patients to get that. And then the other thing I was going to say is I think it's very important to know your family history. And I know sometimes this is something that families are not comfortable talking about their medical history, or things are not discussed over the dinner table. But it's important to know your family history, um, because that can really inform the types of screening that you get, whether that be uh, mammogram or versus MRI. And that can also inform the age at which we would want to start screening. So it's important to sort of be aware of your family history, to have an accurate family history to bring to your primary care doctor. There's all these wonderful models that you can use where you can plug in your own health history and your patient's family history. So, like the Gill model is a good example of this. And you can get your personalized risk of developing breast cancer. And if you have a much higher than normal risk of developing breast cancer, then there are other sort of higher risk screening algorithms that we would recommend that you go down. And one of the things that we have found is that it just the number of patients who should be getting that higher risk screening is much higher than the patients who actually are. So, people are just not aware of doing this. So that would be something else that I would encourage you to, advocate for yourself, and make sure that you know that information and that your providers know that information, so they can make sure that you're getting the most appropriate screening.
Yeah, that makes sense. Well, thank you for that. And there's one last statement from an anonymous attendee: be a problem until they figure out the problem. I like that. Yeah, for sure.
Always helpful to make sure that you're advocating for yourself, for sure.
Well, with that, I really want to thank you for being here today, taking time out of your schedule to present for us. I found this very informative, and I think everyone in our audience did as well. So thank you for that. I'm going to share the recording, maybe see when it finishes processing to the cloud, but I will send it out to everybody who's registered. And then it goes onto our YouTube channel. We always put it on our YouTube channel. So thank you so much for being here and for everyone attending.
Thank you, everyone. It was wonderful. I appreciate the opportunity.
All right. Take care, everyone. Bye. Be well.